The House Health Policy Committee will come to order. Would the clerk please call attendance?
Chair VanderWall.
Present.
Representatives Thompson.
Present.
Mearman.
Here.
Tisdall.
Here.
Beerline.
Here.
DeBoer.
Here.
Preston. Schmaltz.
Here.
St. Germain.
Here.
Bonak.
Here.
Frisbee.
Present.
Whitsitt. Carter.
Here.
Whitwer.
Here.
Neely.
Here.
Hoskins.
Here.
Foreman. Mr. Chair, you have 15 members present. You do have a quorum.
Thank you, Madam Clerk. Appreciate that. Representative Frisbee moves to adopt the minutes from the March 5 meeting. There being no objection, the motion passes. Today we are going to be voting on House Bills 4077 and 4078, which we heard testimony on last week from Representatives Rogers and Mueller. Then we're going to be taking testimony on House Bills 4037 and 4038, which were introduced by Representative Rogers and myself. First up, we'll take the votes on House Bills 4077 and 4078. Representative Bonak moves to report House Bill 4077. Before that, I do want to read in a couple cards. House Bill 4077 and 78, not wishing to speak in support. Mary Pollock, Michigan Employee Retirees Association, and the same bills, Bill Zagman, Michigan Association of County Clerks. So with that, the floor, we will ask that Representative Bonak moves to report House Bill 4077 to the floor with recommendation that that bill passes. Clerk, please take the roll.
On the motion to report, Chair VanderWall.
Yes.
Representative Thompson.
Yes.
Mearman.
Yes.
Tisdall.
Yes.
Beerline.
Yes.
DeBoer.
Yes.
Preston.
Yes.
Schmaltz.
Yes.
St. Germain.
Yes.
Bonak.
Yes.
Frisbee.
Yes.
Whitsitt. Carter.
Yes.
Whitwer.
Yes.
Neely.
Yes.
Yes.
Foreman. Mr. Chair, you have 15 yeas, 0 nays, 0 pass. The motion prevails.
Thank you, Madam Clerk. House Bill 4077 is reported with recommendation. Representative Schmaltz moves to report House Bill 4078 to the floor with recommendations that the bill pass. Clerk, could you please take the roll?
On the motion to report, Chair VanderWall.
Yes.
Representatives Thompson.
Yes.
Mearman.
Yes.
Tisdall.
Yes.
Beerline.
Yes.
DeBoer.
Yes.
Preston.
Yes.
Schmaltz.
Yes.
St. Germain.
Yes.
Bonak.
Yes.
Frisbee.
Yes.
Whitsitt. Carter.
Yes.
Whitwer.
Yes.
Neely.
Yes.
Hoskins.
Yes.
Foreman. Mr. Chair, you have 16 yeas, 0 nays, 0 pass. The motion prevails.
Thank you, Madam Clerk. With House Bill 4078 is reported with recommendation. Before we go into our next section, will be testimony from Rep. Rogers and myself. I do want to take a moment to welcome a group of medical students from Wayne State University. I hope you find your day here very interesting and a great learning tool. But most of all, everybody on this committee, we want to say thank you for pursuing this field in healthcare. And I just hope that you have a great day. So thank you again for being here today. Now we'll hear testimony from Representative Rogers and myself on House Bill 4037 and House Bill 4038. The committee will go at ease at the call of the chair. Madam Vice Chair, the chair position is yours.
The
Committee on Health Policy will come to order. Okay, Representative Rogers and Chair VanderWall, please begin when you are ready.
Thank you. You know, I miss being on this committee, but I appreciate Chair VanderWall having me back. Thank you, Vice Chair Thompson and members of the committee. My name is Julie Rogers, representative for House District 41 of Kalamazoo, and today Chair VanderWall and I are here to testify again on our health data utility bills 4037 and 8, which are reintroductions of bills from last term, which were 5283 and 4, that passed out of the House with bipartisan support and died in lame duck in the Senate as we ran out of time. This package would create a Michigan Health Data Utility, HDU, to combine, enhance, and exchange electronic health data for various healthcare purposes, including treatment, care coordination, quality improvement, and public health. I have the policy bill, and Representative VanderWall has the funding bill. Moving beyond a simple health information exchange model as currently is operated in Michigan by Michigan Health Information Network, or MyHIN, and implementing an HDU provides the opportunity to modernize Michigan's public health data collection and ensure nearly instant and secure medical record sharing with healthcare providers. Most of us have experienced a family member with an illness or found ourselves in situations where our medical team is flying blindly without a full picture of our medical history, including what medications we are on, allergies we may have, and surgical procedures in our history. Often, medical decisions are made based on limited information that can have literally life and death consequences. These bills strengthen that existing framework that has already been established in Michigan under MyHIN and are a significant step forward in ensuring comprehensive health data is shared no matter what healthcare setting so that the whole person can be evaluated and treated in a comprehensive, individualized manner. By synthesizing and sharing this data through the HDU, Michigan will drive down costs as healthcare providers will order fewer duplicative tests, improve health outcomes, reinforce the whole person care model of medicine, and strengthen coordination between various healthcare provider settings. I want to take a moment to share a personal story from one of my family members. This individual had experienced a multitude of neurological symptoms over the last several years, including balance impairments and tremors, which eventually required placement in an assisted living facility for their safety. About a year and a half ago, this family member developed a fever, which turned into pneumonia and required transfer to a hospital setting. As we checked in daily, I started getting nervous, as each day an older person is in a hospital, the more complications can be experienced. At one point during one of our calls, it was relayed that he could suddenly not get out of bed by himself. When we questioned why, because this had never happened before, we were told that virtually overnight he had started requiring a maximum assist of 2 people. That is, he was requiring 2 trained healthcare providers to mobilize him because it was too difficult, and so he was left in bed for a week, 7 days of immobility. After he was transferred back to his assisted living facility, we received a frantic call from his wife when she went to undress him and put his pajamas on for bed. She discovered that he had acquired multiple severe bed sores and deep pressure wounds. So my husband dropped everything and traveled to help care for our family member. I eventually also traveled several hours to join so that we could sleep in shifts and turn him every 2 hours or mobilize him so that his wounds would heal. We eventually asked for the hospital medical records and compared them to the paperwork at the assisted living facility. And what we discovered while we were playing detective was heartbreaking. Just one of his medications, Cinnamate, had been accidentally left off the medication list when the report was made from the assisted living to the hospital. This medication helps with Parkinsonian-like symptoms by reducing tremors and improving movement and function. It's kind of important. I can't help but think how those bed sores could have likely been prevented had he had the correct medication list. If his medical record could have been shared by the prescribing physician, potentially electronically, many of his complications could have probably been avoided. Maryland and Missouri have already passed HDU legislation in 2022, and since then, 8 other states, including Michigan, have introduced similar legislation. Think of it as a data pipeline or on-demand data highway where the health information can flow upon request for those medical providers who need it best to care for the whole person. Unfortunately, since the time I testified last year, our family member has passed away. My hope is that we pass this HDU package this term to coordinate care and get patients the best health care that they deserve. I will now turn it over to Chair VanderWall, and we are happy to answer questions afterwards. We also have technical experts from MyHIN and Dr. Kevin Bonak.
Thank you, Representative. Thank you, Madam Chair, and members of the committee. I'm going to speak directly to my bill, which is 4078, and is the funding mechanism for the health data utility going forward. It's very simple. It would allocate $6 million during the first or the next fiscal year in the Insurance Provider Assessment Act, followed by $7 million in fiscal year 27 and $8 million in fiscal year 28. Then that would be ongoing funding and adjusted for inflation. We have had discussion on the funding piece early in the process, and while most projects take significant cost to stand up, then less ongoing in funding to operate, the health data utility model does the opposite. As more and more patients use and providers are connected to the system, the price will go up. This is an important issue, as Representative Rogers said. The ability to utilize this data will improve health outcomes in our rural areas and will streamline our system. Our professional medical staff will have access to public health trends as they are happening in real time. It will also prevent people from falling through the cracks by ensuring that their healthcare providers have all the information they might need. Understand that this money is already allocated, it's already in the budget. We're not adding new dollars. This is money that's already there. I'm willing to answer any questions along with Representative Rogers, and we look forward to doing that, and then when we are done, we'll turn it over to MyHIN.
Thank you, Chair VanderWall and Representative Rogers, for your testimony. And before we go into committee questions, I just do have a few questions myself. I'm so sorry to hear about the loss of your loved one. And I do understand the dynamics of medication reconciliation, as I am a nurse who has practiced and did the transcription of medication, and knowing how important it is that what a patient comes in with and they have in their medical record is given to them at the change of facilities. My question for you would be, who would be responsible for the accuracy of that data across this network?
I would think it's similar to what is happening right now. So the person that would be providing the healthcare information from one facility to the next facility, whether that be a nurse, physician, PA, I would think that they're the ones that would still be the one responsible. I would just think that the manner of which that they may have access and be able to do it would be more efficient and more specific and precise should this health data utility be stood up.
Can you elaborate on the specificity of that? Because I know it has to be verbally reconciled.
I think we're going to let MyHIN get into the specifics of the detail of that. And what I would think is it's almost like a double check. So you could have both the verbal report as well as an electronic sending of the person's medications for reconciliation.
Thank you. And then for Chair VanderWall, would this system be an opt-in for patients? And could you please clarify on that?
Yes, it's an opt-in, so the patient that's involved has to agree that they're going to allow their records to be moved throughout the system, which I think is I've always used this as a perfect example. We have large systems here in the lower part of the great state of Michigan. You get into our rural communities where we have few hospital systems or care facilities. This is the importance of if somebody visits, they have an opportunity if they have something go wrong that the hospital can actually access those records. In most cases, it's going to happen when they're on vacation or during a weekend, and the hospital will be able to access that and actually treat the patient the way that they should be treated. And I think the results will weigh themselves, and they'll be excellent for everybody here in the great state.
Thank you for your testimony. Do we have any questions from members? Representative Carter?
Thank you, Madam Chair, and thank you for your testimony. Do these bills require that all health systems participate? Is it a mandate?
I can take that one. It is not a mandate. Currently, most of our hospital systems in Michigan are on this system. As Chair VanderWall described, we kind of envision it being built out in hubs. And so many of our skilled nursing facilities are on, but not all. So the basic primary care facilities would be added kind of first as a priority. But I know one of Chair VanderWall's passion areas is foster care, and so that's another area. Oftentimes, children go from different home to different home, and I see that would be another win for shoring up our foster care system and making sure that if children are on medications, that those lists follow them from home to home.
Follow up, please, Madam Chair.
Yes.
Who's responsible for requesting the records, the patient, the physician, or the hospitals?
I believe it's going to be medical provider. So again, in my example, if you were going from one facility, like an assisted living facility, and then transferring to another facility, it would be a medical provider to another medical provider. I believe there also is a provision for the patient to ask for that record.
Thank you, Madam Chair. Thank you for your answers.
Any further questions? Seeing it, yes. Representative Foreman.
Thank you for your testimony, and again, sorry for the loss of your loved one. My question is, with this data going across these platforms, who's responsible if there is some type of hacking or anything like that? Because we're just seeing this in a lot of places, and so I'm just concerned about patient protection. So that's my only question.
Thank you. Yes, I believe that the entity selected would be ultimately responsible. Currently, that is MyHIN. If we go forward with an HDU, there would have to be an RFP to select the entity. But I think MyHIN's going to testify a little bit to data privacy issues and what they're doing currently. And the thing that is pretty interesting and amazing to me is that it's my understanding that MyHIN in the years that they have been stood up in Michigan have never had a data breach, which is fantastic.
Not seeing any further questions, the Committee on Health Policy will go at ease at the call of the chair.
The Committee on Health Policy will come to order. Thank you, Vice Chair Thompson, for taking over. I appreciate it. Next up, we'll hear from Isabel Paco and Kimberly Batchelor from MyHIN. If they are here, they'll be joined by Tony Duchesne. Thank you for being here, and the testimony table is yours. And if you hit the red button at the base of the mic whenever you're ready, the floor is now yours.
Thank you, Chair, and thank you, representatives, for having us today. I believe we have a presentation that we are going to walk through with you today. I'm not sure if that's going to be pulled up on the screen, or if not, we can just walk through.
No, it should
Okay.
be. Will they allow the professionals to assist us here?
Thank you. Well, good morning, and thank you again for having us today. My name is Kim Batchelder. I'm the Vice President of State of Michigan Programs for MyHIN, and my colleague here.
Good morning, and thank you for having us, Chair VanderWall and members of the committee. My name is Dr. Isabel Pacheco, and I am the Chief Administrative Officer for MyHIN.
Okay, so for those, we're just going to give you a brief overview or kind of highlight. I know that the testimony that we had before in some of your information packet, there's a lot of HIEs and acronyms and MyHIN. So we thought we'd start off with a little bit of a brief history about who MyHIN is. So MyHIN is a statewide nonprofit health information exchange with the goal of continuously improving healthcare efficiency, quality, and patient safety by promoting secure electronic exchange of health information. Michigan Health Information Network, or MyHIN, represents a growing network of public and private organizations working to overcome data sharing barriers, reduce costs, and ultimately advance the health of our Michigan's population. So MyHIN was created in partnership between government and healthcare stakeholders throughout Michigan in 2010 to help connect the different technology systems that healthcare providers or healthcare systems use to share data to support care coordination and ensure Michiganders receive the quality care they deserve. MyHIN is currently connected to the majority of our traditional healthcare settings like hospitals, payers, large health systems, pharmacies, and Michigan Department of Health and Human Services, where we help support public health reporting from to their state registries and data needed for their Medicaid program. Thank you. So a health information exchange, or HIE, that you've been hearing, is a network solution that enables healthcare providers and traditional healthcare organizations to securely share patient information electronically between systems that would otherwise not be connected. Every system connected to the Health Information Exchange follows data standards, privacy, and security rules to ensure the right information is sent to the right provider at the right point of care. HIEs are vendor agnostic, meaning the healthcare organization connected to HIEs can use their vendor of choice and share information from different electronic health record systems. So there's a majority of health records across the state that can connect once and share multiple times. So a health data utility leverages existing health information exchange infrastructure and has similar goals related to care coordination between traditional medical settings. However, a health data utility expands its network to non-traditional healthcare settings like schools, foster care, and local public health to increase access to treatment, expand care coordination to those non-traditional sites, increase quality improvements, and is a vital tool for our state's public health initiatives. Nationally, the need for broader data sharing strategies is being recognized, and states nationwide are moving towards health data utilities. Many of these states on the slide are in the legislative process or have legislation in place. Establishing a health data utility aligns Michigan with these states' efforts to modernize healthcare data exchange and enhance our public health capabilities in Michigan. Unlike traditional health information exchanges, which focus primarily on clinical data exchange between the traditional medical providers, again, a health data utility serves as critical state infrastructure, facilitating broader data sharing across multiple sectors to improve health and reduce costs. A health data utility offers a sustainable, cost-effective solution that goes beyond traditional health information exchange to create economies of scale, reduce administrative waste, and enhance data-driven decision-making across multiple care settings. So currently, there is no law that establishes the need for statewide data sharing through a health information exchange or a health data utility. Therefore, we are seeking support to codify and formally establish a health information exchange organization to serve as a health data utility to increase data sharing that promotes security, establishes rules, integrity, and use of data according to all laws and regulations that protect that data across multiple sectors our residents seek care. Key benefits of health data utility. will bring to our state are it improves data exchange systems to support non-traditional health data to be shared securely in per the laws and regulations that govern that data. It promotes cost savings by reducing healthcare waste, administrative burden, and IT costs across providers, payers, and public health agencies. Supports public health preparedness through access to better data for crisis response, and improves economic growth for creating state-level data infrastructure, workforce development opportunities, and health IT job creation. And with that, I'll transition over to Isabel.
Thank you, Kim. Okay, so as you can see from this depiction, healthcare data sharing has evolved, but gaps remain in ensuring seamless, secure exchange across all sectors. Current data sharing infrastructure is fragmented, limiting access to critical patient information across traditional and non-traditional healthcare settings. The future lies in a health data utility, which builds on existing legal and technical infrastructure to improve care coordination and health outcomes. Data security is foundational to an HDU. It adheres to all federal, state, and local regulations, including HIPAA, high trust, and direct trust standards. Patients do have control. They can opt out at any time through a clear and accessible process. An HDU protects patient data while enabling critical health information exchange for better care delivery. MyHIN is a leader in Michigan's healthcare cybersecurity efforts. We're a member of the Michigan Healthcare Cybersecurity Council, a private-public partnership established to safeguard critical healthcare infrastructure. Rigorous security measures are in place. All employees undergo annual cybersecurity training, and HIPAA regulations require data be encrypted in transit. At MyHIN, we encrypt data at rest and in transit. We have no history of data breaches, and we do take security seriously because patient trust is non-negotiable. Strict access controls ensure only authorized entities with a verified active care relationship can view data. Here you see the garage door security model. If a data breach is detected, all data exchange is immediately halted. The issue is resolved before reopening data access, ensuring maximum security. This approach protects patient data while ensuring uninterrupted care once security is restored. So what if I told you that in the middle of a cyber attack targeting Michigan's healthcare system, a hospital's electronic health record system was compromised, but patient care was never disrupted? With an HDU in place, the garage door security model immediately shuts down the affected data pathway, preventing hackers from spreading further or accessing sensitive patient information. Meanwhile, authorized entities with the verified care relationship, like a treating physician or hospital, still retain local access to their patients' data, ensuring that critical treatments continue without a delay. The result? The security threat is contained, neutralized, and resolved before the garage door reopens, protecting patient data while ensuring uninterrupted care. This is why Michigan needs an HDU. Security is not an afterthought. It's a built-in safeguard that keeps patient trust intact while allowing healthcare providers to do what they do best, deliver quality care. HB 4037 formally establishes an HDU in Michigan to create economies of scale, reduce administrative waste, and enhance data-driven decision-making for providers and policymakers. The key requirements of an HDU in HB 4037 are high security standards. Vendors must meet common security framework, a competitive bid process to ensure cost-effectiveness and sustainability, builds on existing infrastructure to avoid duplication of efforts, and coordinates with the state to ensure the prioritization of needs for Michigan residents. And HB 4038 leverages the Insurance Provider Assessment Act to fund Michigan's health data utility without increasing the state budget or relying on taxpayer dollars. The IPAA is an existing sustainable funding source designed for healthcare infrastructure investments like HDU. By securing this dedicated funding, starting at $6 million in year one, $7 million in year two, and capping at $8 million, Michigan ensures long-term, cost-effective data sharing without creating new financial burdens. Delaying action means higher cost and missed opportunities for better healthcare coordination. Michigan cannot afford to delay action and lay the groundwork for a more efficient, secure, and cost-effective health data sharing system. And finally, I'll say a health data utility is not just about data, it's about people. It ensures providers have the right information at the right time to deliver better care. HB 4037 and 4038 establish a secure, sustainable, and forward-thinking data sharing infrastructure that benefits patients, providers, and health outcomes. Michigan has the opportunity to lead. Now's the time to act. Thank you.
Thank you both very much. We'll move to questions now. First question goes to Representative Frisbee.
Thank you, Mr. Chair. I've heard just one conflict that has me concerned this morning. Earlier we heard opt-in, and I just read opt-out. So I need some clarification as to which one it is.
Absolutely. So when patients go to their providers at their physician's office, they do sign forms, the HIPAA forms, where they are giving permission for treatment, payment, and operations of their care, and so that is their chance to either sign the form or decline to sign the form, and that is where they're opting in to the data sharing model.
And then the opt-out could come at any point later.
Absolutely, yes.
Okay, thank you.
Thank you. Representative Meerman.
Thank you, Mr. Chair. MyHIN has been around for a while. I understand the idea of what we're trying to do is codify it and expand it into, elderly care, foster care, and the others. Who's paying for what MyHIN is doing now?
So currently, thank you for your question. Currently, we work with the legislature to receive general funds, and we actually work with the department to receive federal match. That is our current funding model today.
Hospitals, other partners paying in?
We do have other participants in our network. We do have payers who are participants in the network, and yes, they do pay a portion.
So it's functioning, Mr. Chair, it's functioning at the hospital level, but not between home care or elderly care in the hospital?
Right. So what the difference between an HIE and an HDU is that we're taking the traditional healthcare model, data exchange model, and moving it into a more non-traditional healthcare space. So making sure that we can take care of the whole person holistically, not just the providers they see at the hospital, maybe a specialist. There's oftentimes gaps in information sharing between different types of providers. And so this health data utility will include those other providers who aren't currently part of the network.
Thank you.
Thank you. Representative Preston.
Thank you, Chair. Quick question, one of my main priorities, patient data access registries. I'm reading, in the language so far, how does your company, if selected, how would it facilitate that access if requested by the patient or their power of attorney? And the mechanism, that would be used for them to access that data. And then if you wouldn't mind, I have a couple other questions as well.
Absolutely. So patients can access MyHIN for requests several different ways. We do have a help desk that they could send an inquiry into. We have a call-in number they can actually call into as well. We have information online that they can access to make a request. And if we do receive such a request, it would be handled by our security and privacy officer. And the information is kept at MyHIN for any information that who's accessing the records for each individual patient? Should that be a request of the patient?
And then for small rural providers, how will they be, I guess, taken care of in this new system without suffering, an egregious financial burden, regarding the technology to allow them to participate in this? And I'm
Right.
talking about providers up by me that are single doc facilities.
Right. So you're mentioning that they would lack the infrastructure and maybe the resources to be able to participate in an exchange of this nature. I think that's the reason why the HB 4038, is important. If we secure, one, the implementation bill is passed, and then the funding bill subsequently, that would help us to help them to be able to connect to our system. We do realize there are many entities who may lack the resources to be able to connect in various ways, and so we're here to help.
Yep, and let me add to that as well. We do, as the current Health Information Exchange, have tools that they can access, understand if they don't have a care management platform or electronic health record for like those small kind of one doc shops. We do have a system called My Gateway, which is a portal they can access some of their patient. If they have that relationship with the patient, they can access some of that information as well through that portal. So.
And then finally, have you guys finished your movement over to a cloud-based system? I believe Amazon possibly, and your new integrated platform. If that's complete, have you run your own security stress test on the new platform? What were the results?
Absolutely. And yes, we are web-based. And we have run our latest high trust, our direct trust security measures. We have passed all of our assessments. And just last week, we were awarded the Direct Trust Award for our 2-year assessment of direct trust certification. So yes, we would say that, well, we do stress test of our system on a regular basis. And as I mentioned before, we do make sure that all of our staff is trained on security every year. As a matter of fact, most of them, any of them who are watching have probably done it this week or are about to do it by the end of this week. So yes.
And I have one final, I'm sorry. If a patient opts out after years of participating in the system, is their historical data firewalled?
If the patient opts out, we immediately stop data sharing without question.
With all historical data?
Any data, yes.
Okay, all right. Thank you.
Thank you, Representative. Representative Carter.
Thank you, Mr. Chair, and thank you for your testimony. I'm always concerned about accessibility and affordability of any type of insurance. And I would like you to once again explain to us how HIEs are funded, and if you'd be so kind to elaborate on how the HDU would be funded and where would that funding come from, I'd appreciate it. Thank you.
So currently, the Health Information Exchange, I think as Isabel mentioned previously, we work with our state legislature to receive general fund money, and then we take that and work with the Michigan Department of Health and Human Services to receive some federal match money to make that money go further through some of those funding mechanisms. Then we partner with the department on ensuring that the projects or data needs that they need are established in our Health Information Exchange and our data flows. We also do have hospitals and payers that are connected and pay certain fees in order to receive data that they are requesting, particularly from the health data utility. As the Health Information Exchange, I should say. So currently, that's really how MyHIN is funded. As a health data utility, according to the bills, it's the insurance, the IPA, Insurance Protection and Portability Assessment Act. Sorry, I always lose track of the acronym. And through that funding model, that's general fund requests that MyHIN has been receiving for the past 7 years would go away, and this would replace that if MyHIN were to receive the nomination for health data utility.
Go ahead.
Okay, I think I read that there would be an increase to the tune of maybe $6 million per year. Okay, can you explain that if that is the case?
In the bill right now, currently, it's $6 million for the next fiscal year. The next year would go up to $7 million, and then it would cap at the third year at $8 million with the CPI or inflation. So it would be $8 million, not all combined. So And that's one of the reasons why it goes up, that model, the price increase. The more participants, the more data, the more protection, the more servers, infrastructure you need to support that protection of that data.
Follow up, one last one. Thank you for this information, very valuable. So this information would be coming from a restricted fund, or would it be coming from the general fund? I mean, this increase.
I believe that's from the IPA, which is a
Yes, I guess I'm not understanding the IPA's function. Thank you.
If I may, to answer your question, it is a restricted fund. So this is not general fund dollars. There is no increase to taxpayers under this project, and it is this restricted insurance fund. Thank you.
Thank you.
Thank you, Representative. Representative Thompson.
Thank you, Mr. Chair. Thank you, ladies, for coming and giving us all this wonderful information. I do have a couple questions, if I may. Number one, it does appear that the goal of this could also lead towards promoting better analysis of overall community health outcomes and the clarification of that, the public access to the information of health outcomes and different dynamics of our society. How do we know that this is really geared towards making sure that patients have the access to the care and the doctors have access to the information, and that it's not just kind of a data grab or getting information from people's private health records that people don't feel comfortable sharing?
Absolutely, great question. As I mentioned, we only share data with trusted data sharing organizations. Each organization who agrees to participate in our network must sign legal documents that we currently have in place today, and we would expand towards other entities who would become part of this network. If you do not have a legal agreement and you are not a trusted data sharing organization, you do not have access to the data.
Okay. And then, so they would be held under the HIPAA criteria?
Yes, absolutely.
Okay. And then in the analysis, when we talk about the social decision-making of this data, what organizations would have access to this data other than people that were protected under HIPAA, other than healthcare providers? Would it be food banks and transportation department and other departments? And if so, how would that data be given to those non-government entities?
Absolutely. So the intent to share data with entities such as you mentioned, a food bank or a transportation service, is not to share the patient's entire medical record. The intent is to flag the patient's medical record as having a food insecurity or a transportation need for healthcare services, and to connect that patient with the service. So that is the intent. The services themselves should not and would not get access to the full medical record of a patient.
Yep. And just to add to that, that's only if the patient consents to receiving those services. So for instance, if I was, visiting my provider and I told my provider that I do have a food insecurity, and my provider asked, would you like me to refer you to receive some help with that in the community? And I say, yes, I consent for my provider to be able to refer me. So that information would be then only, and it's just enough information for a local community, like food bank, for instance, or food resource, to contact me and follow up to help me with my food insecurity. That's the only information that would be shared. It would not be any medical information, just contact information and my name.
But wouldn't the provider be able to do that right now?
I think from what we hear from our providers, and we do have a doctor that's going to testify in a little bit, but what we're hearing from our providers is that it's very, they're busy at the point of care. We're trying to make it easier, ease the burden off our providers to be able to have them not have, and their staff have to research some of the community information or the community resources, phone calls, faxes, et cetera. We're trying to make this electronic and ease that burden off our providers to be able to easily refer that patient to receive that need that they identified.
Thank you.
Thank you, Representative. Representative St. Germain.
Thank you, Mr. Chair. I always wondered why it was so difficult sometimes for patients to access their own records. Will this system provide procedure codes and itemized billings, those type of things? Will they be able to access those?
The information that would exist in the system would be their information that's kept in the EMR or medical record chart. So we do have things like diagnosis codes. I can't speak to, at this point, whether we'd have medical billing information there. We can certainly think about that and see if that's something that makes sense to put into the system at this point or in the future. But you're right. I mean, accessing medical records for each individual, it takes a pretty big act to be able to get that for yourself. So, yeah.
If I may, Mr. Chair, it would be helpful to me anyways to kind of visualize the system. I don't know if there's a way we could get something like that, you know.
Certainly glad to work with them on that. I think that
Sure.
that we're not rushing this, so absolutely we'll see what we can do. Representative Meerman.
Thank you again, Mr. Chair. So these providers paying into the system we have today, what would happen to that money that they're paying in? Is it still going to occur, you might say?
Right. We would have to establish what the new funding model would look like, seeing as though we get these funds. So remember today we get federal funding from the general fund, or we get funding from the general fund and we work with the state to get federal match. In addition to that, there are other portions of the business where hospitals and payers actually access data in our system and provide data to our system. And there are fees associated with that. That model, that part of our model would not change.
And are they paying sometimes to get information, or is this a yearly thing, or?
Yeah, we have a funding mechanism that we can share with you separately if you're interested in seeing that.
Thank you.
Thank you, Representative Beerline.
Thank you, Mr. Chair. If we could just go back to follow up on Rep. Thompson's question, can you define a trusted data organization? Like,
A trusted data sharing organization is the term that we give to the participants in our network who have agreed to the legal terms of participation. So that is what we call a trusted data sharing organization.
I guess, so you could change that at any time, but I've submitted my I've agreed to participate in your system as a patient. And then you can share that data, but you could change what that is. I feel like that needs to be better defined than just.
I'm sorry, can you clarify your question? I'm not quite understanding.
Okay, so you're saying that you're going to set up a framework for what a trusted data organization is, or whatever. If
there is an
whoever
existing
the HDU
framework,
is.
yes.
You could change that if you're in control of that. If it's not defined in the legislation, you can change who and what a trusted data organization is after I've already submitted to give you my data. So if you're going to change who can access it, I should be able to, at that time, I almost need to be notified so I can reassess if I want to continue sharing my data, or it needs to be defined in the legislation.
Absolutely, I understand your question. Thank you for clarifying. We don't make up what a trusted data sharing organization is. We have to abide by federal and state laws. We have to make sure we're abiding by HIPAA. When we pass the HDU legislation, we will have to revisit what that looks like for additional entities added to our network. So no, we don't change it on a whim. We don't have the authority to change the laws. We have to abide by the laws.
So there is a law that currently defines what a trusted data organization is.
There are HIPAA laws that are in our agreements, and that is what we have to adhere to.
Okay. If I may.
Yep,
sure.
Absolutely.
And then our existing hospital network, they use different not data collection. They use different charts, whether it's Oracle or Epic or all of these kinds of things. How does MyHIN replace that, or does it work with each one of those individual?
Yeah, that's a great question. No, we're think of us as like the data plumbing. So each system, each healthcare provider, each payer, each pharmacy, they all use their different EMRs or electronic medical records or electronic health records. That will still stay the same. we're vendor agnostic as that plumbing. We connect to multiple of those. So the provider at Sparrow down the road would still use their, Epic EHR. That's EHR would connect us, and that's how that provider would receive information from different systems that they may have to refer to Michigan Medicine or, someplace other that uses a different technology system. That's where we come in the middle and connect all of those technology systems so that data flows, so that information, when they log into that Epic or that EHR, is there for them.
Thank you, Representative. Thank you, ladies. Seeing no other questions, we appreciate you being here. And at this time, I will ask to hear from Dr. Kevin Bosack with the Michigan State Medical Society. Dr. Bosack, thank you for joining us, and you begin your testimony at any time.
Thank you very much. Good morning, Chair, members of the House Health Policy Committee. I was looking forward to saying hi to the med students, but they left, so that's kind of a bummer. Honored to ever be in the presence of people wanting to go into medicine. So I'm a family doctor, currently precept as an attending physician with a training program for a large healthcare organization here in Michigan. I also retired out of the military after 28 years in the Michigan Air National Guard and active duty service as a flight surgeon. Served all over the globe and now proudly here in Michigan for the past 14 years. Finally, I serve in a statewide leadership position as the Executive Medical Director for Population Health Management, actively engaging with high-risk patients, ensuring good transitions across the continuum of care. Associated with this role, I am a board member of MyHen, representing health systems. I'm here today to express my support for House Bills 4037 and 4038. As a physician, I cannot overstate the importance of having timely, comprehensive, and accurate patient information available to make critical care decisions. These bills take a significant step toward ensuring that essential health data is securely and efficiently shared across the health system, ultimately improving patient outcomes. Every day, physicians like me encounter situations where a complete picture of a patient's medical history is essential, whether it's knowing which medications are prescribed, understanding their history of chronic conditions, or being aware of recent interventions in the hospital or emergency department. Access to up-to-date information can mean the difference between a well-informed treatment decision or one that lacks critical context. Currently, our state's HIE, operated by MyHen, plays a crucial role in facilitating electronic health data sharing. Unfortunately, it remains limited in scope and functionality. Under the existing model, important sources of data, such as emergency responders, schools, or community-based organizations, are excluded from sharing vital health information. Gaps in data sharing can create barriers to effective care coordination and inefficient use of resources, including referrals that are lost to follow-up, wasted costs through redundant testing, and even unnecessary medical errors. House Bills 4037, 4038, they address these limitations by establishing the HDU model, which would enhance and integrate health data from multiple sources while maintaining compliance with federal and state privacy regulations, including what we've talked about a lot, HIPAA. By expanding the types of entities that can securely contribute to the exchange of health information, we can ensure that all relevant patient data is available at the right time, with the right provider, in the right place. This is particularly crucial for patients transitioning from different levels of care, such as from a hospital or rehab facility to somebody like me as a primary care provider, where missing or incomplete records can lead to dropped batons, as I call them, or fragmented and inefficient care. The HDU model is not just about improving efficiency, it's about saving lives. By ensuring the seamless flow of information, these bills will help prevent medication errors, reduce unnecessary hospitalizations, and improve the overall quality of care for Michigan residents. Moreover, this aligns with national efforts to enhance healthcare interoperability, ensuring that Michigan remains at the forefront of innovative and patient-centered care delivery. I urge you to pass and support House Bills 4037 and 4038 to empower physicians and healthcare providers with the information we need to deliver the best possible care. Thanks for your time and consideration, and welcome any questions you may have. In fact, I took a few notes just to add on to some of those really good questions. Representative Thompson, you asked about how you could interface with somebody that might need a need. Right now, I basically can refer to a person. Sometimes it's a community health worker or social worker. Then that person has to reach out and try to find some organization that helps with transportation or food, we still have this people interface when a patient describes a need. And I can tell you, talk about wasted time and effort, it's not unheard of where we have a no-show appointment, which is a huge opportunity cost, right? And maybe not me as a PCP, but oftentimes, say, a cardiologist seeing somebody in follow-up for heart failure, and they no-show 2 days after being out of the hospital. What does it turn out to be? They didn't have wheels. They missed out on the transportation thing. So when we're relying on all these people to try to connect to some of these other places, we have some drop batons there too. And so for the mechanisms that were described, and I guess I'll channel my military need to know, which I think is, that was another component, right? Need to know information. Like, hey, they need a follow-up, and they need transportation. We wouldn't share with them, oh, they have underlying CHF and their body mass index is this and that, right? It's, hey, can you get them wheels to go from here to there? That would be a win for everybody. Because I can tell you, I have a very upset cardiologist on the line when I, as a medical director, have to deal with trying to coordinate that care across the continuum. So that's just one example of just trying to connect those dots that I think that you touched on very well. Another note I think I made, just unnecessary testing. In Monday, I was in clinic. I precept residents, and I said, hey, you know what? I'm doing this testifying on Wednesday. What do you guys run across? And along those same lines of just connecting the EMRs, they were describing how somebody could have a CAT scan of somebody's head or an echocardiogram at another center, and that's not always available to when they're taking care of a patient in one of our hospitals. And so they end up repeating it. What a waste. You know what that does? That's a cascade. Now that patient's unnecessarily taking an appointment for somebody else who's in the ambulatory setting wanting to have an appointment. So it's all interrelated. If we can just increase some efficiencies, decrease costs, and we'd all be better for it. So those are just examples. Medications were another thing that they actually mentioned. So there are community or clinics that aren't on that sharing mechanism. So they were actually describing day number 4 of a patient's inpatient stay, they found that a patient had been on an opioid out in the community and they didn't know about it. So they were effectively potentially overdosing pain medications because they didn't know what the patient's list looked like from that other entity. And so that concept of medication reconciliation, I think that Rep. Thompson, you talked about, reconciliation is taking a list of what you think the patient's on, what somebody else has it on, and then reconciling that to make sure that you know the comprehensive list. And really, that's what this data sharing ultimately enables. So just wanted to reflect on some of your really great questions, because that's important for me as a provider to say how important this sort of thing would be.
Thank you, Doctor. Any other questions from the committee? Representative Meerman.
I'm assuming once everybody's sort of in the system, this is real-time data? Like a doctor's the patient sitting in the office, doctor can look it up?
Yeah,
is that right?
Actually, that brings up another good point. So MyHIN has a fairly innovative program called ACRES, Active Care Relationship Service. So what that means is that I, as a provider, have to essentially vouch for the fact that I'm taking care of that patient. Again, adhering to HIPAA, high tech, whatever these people know about. I'm just the caveman family doctor here, right? But if I have that active care relationship, then I'm privy to that information. But if I don't have an active care relationship, I can't grab data from anybody and try to, look at that sort of thing. You have to have a relationship with the patient. Then you're privy to, for example, that CAT scan done somewhere else, the echocardiogram result, the medication list. So it's not like you're just reaching out and grabbing data. That has to be that vested interest in an organization and the provider taking care of that patient at point of care.
And then it would be real time if you have that.
Yeah, then
set
it's
up.
real time, and it's actually quite excellent. We have a hyperlink within our EMR. So there was a really good question. EMRs are connecting to EMRs. In fact, you're in a different EMR. So Julie's on a different EMR than I am. And so the nice thing about that exchange is the echocardiogram done in one EMR can be seen by somebody else in another EMR by going to that common space. So that's the way that works.
Thank you, Representative. Representative Thompson.
Thank you, Mr. Chair. So getting back to that EMR to EMR, I kind of want to figure out how that works, because I do know that different systems are on different systems. So for me, as a downriver nurse, it was Corewell and Henry Ford, and it was Epic. So if you log into your electronic MAR and you're caring for a patient, is this a separate app, this data utility that you would go to? Because if you have to get it into the different electronic MARs, the electronic medical records, is it going to be a tab that you click on, or does it already integrate the information for the lab results and the test results? And, the last time that they had a blood test, or what is that going to look like? That would be my first question.
Well, I can say how it is right now. It is a hyperlink tab where through what's called single sign-on, I'm inside my own EMR, and that gets me into that gateway that was being discussed before. So then I can find that random test from another EMR and then be able to know what that result is for comparison. And so that's you're privy then through that established care relationship through single sign-on to get to that portal to then see those different things.
And that portal, would that have physician's notes, nurse notes, test results, and just basically everything that you would have access to in their medical record?
So that's the way I see it right now. I can't speak for what an HDU looks like further on, but I would imagine there's some interoperability there. Elizabeth had preferred.
Yes.
Or is it Isabel?
It's okay. It happens all the time. But to answer your question, yes, the information that is fed from, there's standard data formats that are used. So we select certain fields from the standard data formats that are used from the EMR systems. So you may have heard of an ADT. That's an admit, discharge, transfer notification. It's exactly what it sounds like. Those are the fields that we grab from the EMR system and give over to a participating active care provider. We have continuity of care documents as well. There are standard formats there with only specific information as far as the data set goes that comes from the EMR system. So we're not recreating an EMR system, if that's what you're asking.
No,
That is not.
I don't see it as being that.
Yeah, it's essentially read-only then? That's a good
yeah,
point. So
yeah,
it's
yeah,
a
that was what,
if that
exactly.
makes sense?
Exactly.
Yeah,
that's
so
what
there's
you're
no addition except from the host EMR that you're using.
One last question, if
Absolutely.
I may. If this were in place in 2020, would this have made getting information on who was vaccinated and who wasn't, would it have made that information more accessible?
That's a great question. I mean, we already have MICR, which is the immunization registry for Michigan, and so I believe those immunizations were already uploaded into MICR. So I'm not sure that is necessarily different under HDU versus what we're doing right now. And I can tell you that's an important safety component, not just for COVID, but really any sort of vaccination, because you don't ever want to have, say, one pediatrician give a particular vaccination and then a family doctor that takes over their care to not know what was given in another office, right? So,
Pharmacies.
yeah, good point too. So, if any pharmacies are giving immunizations, they upload to MICR. So again, that's an important safety component, I believe already built into the system. But
Absolutely,
okay.
yes.
Okay, thank you.
Thank you, Representative. Representative Preston.
Thank you, Chair. You guys may have already covered this. Just to recap, there's several states that have health information systems in place. Washington and Wisconsin, that's the one that I'm the most familiar with on Epic. I've used it several times during patient care. But what is specifically the difference when you go from a localized health information network like an HIE to an HDU? What do you go from and become?
Right, you go from the traditional model of healthcare data exchange for provider to provider to adding the other entities into the ecosystem. Like on the depiction, I'm sorry, the presentation is gone now, but you probably have it in your packet where the other entities are added, such as EMR. I'm sorry, emergency ambulance, foster care, the issues with food insecurity, transportation, et cetera, those are the entities that don't exist in the HIE space today.
And just to follow up, it seems like the nation's been slow to embrace HDUs. There's just a few of them that are fully implemented. Why is that?
That's a great question. If it were up to me, it would have been enacted, years ago. This is something that the country has gotten used to, a health information exchange. Not every state has one. Those that do are finding more and more value in a health data utility model. And several states, as we showed on the screen earlier, are either already have health data utility designation or are in the process, such as we are, to get legislation established.
I'll add one more thing with the value of this exchange, that on a hospital system basis, they was talking about the funding models. What's the why behind that? Our partnerships with payers, we're feeding quality data, again, along the same of those lines. If somebody had a mammogram colonoscopy, they're receiving some of those quality data through the MyHIN mechanism of quality reporting. And what that does, if you think about it, improves quality of care for prevention of things that we want to prevent, but also, again, reducing redundancy. You don't want to repeat a colonoscopy, if anybody's ever had to do that, more than every 5 years that is prescribed or whatever. And so there's ways that we can exchange data through our payers who are giving us rewards. So what's the return when we invest in an entity like MyHIN to send quality data? We're actually getting payer incentives through our contracts to improve quality of care. And so again, there's an ecosystem there that has been fostered here in Michigan that's fairly unique. We as providers and payers work together, which is why we have payers very involved with MyHIN, just as much as hospital providers and physicians and other entities. So it's really an amazing partnership that the state of Michigan has that has been, I think, at the forefront, if you will, for doing a lot of these things.
Thank you. Representative Frisbee.
Thank you, Chair. Currently, I believe HL7 is the standard for reporting. How far are we away from a change, and what impact would that have on you financially and operationally?
Yeah, we do use HL7 standards to exchange data. And when the standards are updated, we follow and adhere to the updated standards. So I don't see that changing.
Do you see any financial impact of that change for you?
Not necessarily. If there were financial impact, I think that with the funding mechanism that we have in place, it should support that infrastructure.
Okay, thank you.
Representative Schmaltz.
Thank you, Chair, and thank you for testifying. Following up on Rep. Preston, what he said, have you had any opposition to adding certain entities from them about being part of the system? And what about other health utility sharing organizations? Have you had any opposition from them as being part of this?
So the second part of that question, if we have opposition from other health data utilities about Michigan participating? No opposition. As a matter of fact, I think we all support each other in this endeavor. And the first part of your question was, did we have opposition from other
entities that you want to put into the system that aren't currently in the system?
Yeah, I haven't received opposition at this point. Obviously, we want to work towards connecting those facilities once the legislation's passed. So at this point, we haven't had opposition.
And if I may, just as a follow-up, again, it's voluntary. So while hospital systems are on individual, for example, primary care, could opt in and decide. This would not be a mandate for any independent healthcare provider.
Very good. Seeing no other questions for you, thank you for your time today. We greatly appreciate it. We have one other person that would like to speak, Larry Wagonette. Larry, if you would make your way up when you're ready, I believe the light is already on. The testimony table is yours.
Thank you, Representative VanderWall. My name's Larry and members of the committee. My name is Larry Wagenknecht. I'm a pharmacist. However, I'm here today as a dad. Dad of my 5-year-old son, Jason. Unfortunately, Jason died in January of 2022. from complications of leukemia. During the 6 months preceding his passing, Jason underwent many blood tests where there were blood draws, including bone marrow aspiration or bone marrow samples. And unfortunately, at least 4 different times, he had, building on Dr. Bonzak's comments of repeated tests, unnecessary tests, he had at least 4 separate situations where an additional blood draw was required because the information was not available to the healthcare team that they needed at the time. One time, an additional bone marrow aspiration sample was required because the information wasn't there. Jason always referred to these as pokes. And obviously, as a 5-year-old child, that's not a good situation. Since he's passed for the last 23 years, it's been one of my goals to support technology and systems that hopefully would eliminate these unnecessary pokes and that children have. I encourage you to support House Bill 4037 and 38. Thank you.
Any questions from the committee? Representative Schmaltz.
I just want to say, thank you, Mr. Chair. I just want to say thank you for coming to share your story, and we're very sorry for your loss.
Yeah, thank you.
Thank you. Thank you, Larry. With that, we have a few cards to read in. Kate Dorsey, Michigan State Medical Society, not wishing to speak in support of the bill. Eric Roth, Michigan Pharmacists Association, not wishing to speak in support of the bill. Dr. Scott Monteith, MD, not wishing to speak in support of the bill. Greg Foley, MD, not wishing to speak in support of the bill. Tom Simmer, MD, not wishing to speak in support of the bill. Dr. Fazaz Seiss, not wishing to speak in support of the bill. Dr. John Vismer, MD, not wishing to speak in support of the bill. Helen Hill, not wishing to speak in support of the bill. Larry Weckenut is no, not wishing to speak in support of the bill. Janie Tice, HIT Commission, not wishing to speak in support of the bill. Dr. Dennis Smith, not wishing to speak in support of the bill. And Amanda Klein, American Heart Association, not wishing to speak in support of the bill. Representative Hoskin moves to excuse absent members. There being no objection, the motion prevailed by unanimous consent. There being no further business before the Committee of Health Policy, the committee will stand adjourned.